Bismillah ar-Rahman ar-Rahim. I would like to thank the organizing committee for this kind invitation. I was asked to give a talk about the approach to CBC, so I made it in a case-based scenario, and I'm presenting the common abnormal CBC consultation that we encounter during our daily practice. So my objective is to talk about the CBC indices and to take you over a case-based scenarios on common WBC, RBC, and platelet abnormalities. So as you all know, CBC is the commonest lab request done, and even normal individual, up to 20% of patients of healthy individual can have abnormal result. And it's usually done by automated CBC analyzers, which provide you with the number and the size of the cell and flags any abnormal results found. So platelet and RBCs are usually detected through one channel and classified according to their size. So small size, they will be counted as platelet, and the larger size will be counted as an RBCs. And sometimes if you have a large platelet count, that will be counted as an RBC and giving you a falsely low platelet count, such as in cases with congenital Bernard-Solier. Hemoglobin measurements is done using a spectrophotometric method to measure the absorbance of light at 540 nanometer. And there are few exceptions where you can get high or low levels of hemoglobin, such as smoking, cold agglutinin disease, hyperlipidemia or hypergammaglobulinemia, and fetal hemoglobin. There are other CBC indices that we can see, like the mean corpuscular volume of the RBCs using an RBC histogram to measure the mean volume. MCH and MCHC is frequently physicians get confused about these two and what is their significance. So mean corpuscular hemoglobin is the average amount of hemoglobin in a single RBC. So if you have a low MCV like a small RBC, the MCH will be accordingly low. But the MCHC is the concentration of hemoglobin in a blood volume. And the other parameters are usually counted. So for practical purposes, we usually classify our anemias in our daily practice according to their MCV and RDW. And there are other various formulas used to calculate the different parameters in CBC. And the WBC usually enumerated either manually or by automated machines, and the manual enumeration is subjected to inherent errors, but the automated machines requires a dilution of the RBCs. And as you can see here, this is the neutrophil, and this is a monocyte, which is the largest cell. Eosinophil, which has a secondary granules that's stained pink, and the lymphocyte is the smallest one with a rounded nucleus. So this is a very nice study done on 24 healthy individuals, measuring fasting sample of their CBC by the same phlebotomist. It was done over a 14 days period, and this is to just tell you that within the same individual, there is a narrow range of their granulocyte, hemoglobin, and MCV, as well as platelet. But there are different variation between individuals, as you can see here. So what we have in the reference range in the CBC, that encompass the 95% of all healthy individual. So sometimes you have 5% where you have either a higher than the reference range or lower than the reference range. We'll go over this in a minute. So starting with the first case, a 45-year-old male, previously healthy. He was found to have iron deficiency anemia on routine evaluation. He had no previous medical history and takes no medicines. The iron replacement was started. So which of the following is the most appropriate? I think colonoscopy and upper GI endoscopy should be done. In men and non-menstruating women, GI blood loss is presumed cause of IDA until proven otherwise. So the daily requirement of iron in patients with iron deficiency anemia, the patients should take at least 100 to 200 milligram of elemental iron. For example, if we have a ferrous sulfate that is 325 milligram, it contains 65 milligram of elemental iron. Therefore, you need to take 2 to 3 tablets a day to reach the optimal requirements of oral ferrous sulfate. There are other IV forms that are available with limited indications, like in patients who are intolerant to PO iron, malabsorption, or previous GI surgeries. The response is expected within 7 days, that you can see a high reticulocyte count, and then the hemoglobin start to increase by day 14 and onward. There are patients who are failing oral iron replacement, and you should think about the compliance, continued bleeding, mainly in the GI, or malabsorption. Second case is a 20-year-old male presented to the emergency room with dyspnea and exertion and dark urine discoloration. He had a recent UTI treated with Bactrim. On examination, the patient looks pale, ecteric, with normal vital signs. He has no lymph nodes and no hepatosplenomegaly. His labs showed a hemoglobin of 6.2 gram, and the peripheral smear showing a bite cell, as you can see in the black arrows. And on the Heinz body preparation, you can see the denatured hemoglobin on the RBCs. So the most likely diagnosis here is a G6PD deficiency. So the G6PD deficiency is an X-linked disorder, commonly in male, especially of black ethnic background, and usually characterized by an episodic hemolysis in response to oxidant stress factors such as drugs or infections. The caveat here, don't check the G6PD level at the time of the acute event. So wait 4 to 6 weeks until the hemolysis subsided, then check the G6PD level. The reason behind this, that if you have an ongoing hemolysis, the normal reticulocyte, which is a normal reaction from the bone marrow, contains a normal values of the G6PD. So there are a few questions here to address in G6PD. One is I think the dietary restriction. So we hear about favism, which is not universal in patients with G6PD. So it's more commonly observed in patients with G6PD Mediterranean or Canton subtype. That's in Greek, Italy, and some parts of Middle East. However, the G6PD and dietary restriction was mainly observed during childhood for unknown reason. In adults who were having a history of G6PD, we tend to tell them whether they were exposed to fava beans, for example, falafel. Falafel does contain fava beans. And if they have been exposed and they did not get any hemolysis, then we can tell them, okay, you can get fava beans. However, if the patient doesn't know whether he had previous fava beans or not, then we tell them to take a cautious dietary observation. The second question, whether G6PD can donate blood or not, I think they can donate blood as long as they have a normal hemoglobin, because this part of donation will not cause a clinically significant hemolysis. The third part is pregnancy, I think, which is I commonly encounter a patient who are a carrier and she gave birth to a boy, that she doesn't know whether it's a G6PD or not. Breast milk does secrete some drugs, so she should be careful about some medication that she's taking. And the approach to hemolysis, just a practical, we have to look for emergencies like hemodynamic instability, acute kidney injury, any thrombosis or schistocyte. Then we have to think about thrombotic microangiopathies or acute hemolytic transfusion reaction, and urgent hematology consultation should be made. And then we do a direct antiglobulin test, and if it's positive, we classify patients either they have a warm type autoimmune hemolytic anemia or a cold type. Then we look carefully about their drug history, infection history, any intrinsic factor like sickle cell disease, hemoglobinopathies, membranopathies, or enzymopathies. Paroxysmal nocturnal hemoglobinuria can cause that negative autoimmune hemolytic anemia. And mechanical, if the patient has some prostatic valve that can cause some hemolysis. Case number 3, a 37-year-old female, 1 year post-sleeve gastrectomy, presented with weakness and hemoglobin of 6 and MCV of 110. She has mild neutropenia and thrombocytopenia. She has a decreased loss of vibratory sense. Ferritin TSH RBCs with a normal, and B12 was very low. All of the following are true about B12 deficiency except. So I'll just answer them. So the neuromanifestations are not always reversible. Sometimes you end up with an irreversible neurodamage. Folate replacement may worsen the true B12 deficiency, because if you give folate, that will take all the B12 reserve that you're having. B12 deficiency is uncommon in vegetarian, but it's common in vegans whom they don't take any dairy products and they take only vegetables. Metformin has been associated with B12 deficiency, and B12 deficiency is associated with thrombosis due to an acquired homocystinemia. So, and this is a hypersegmented neutrophil shown here, more than 5 segments in the nucleus, and then the B12 replacement, usually classical, 1 injection daily for 1 week, followed by weekly for 1 month, followed by monthly. And most patients will require a lifelong B12 replacement, as the cause can't be eliminated. And this is the normal metabolism of B12. Here, the intrinsic factor gets secreted by the gastric parietal cells and binds to the B12, and the intestinal lumen gets absorbed into the bloodstream. If you have a pernicious anemia, the intrinsic factor, you have an intrinsic factor antibody that inhibits the binding to B12, while in atrophic gastritis, you may have loss of intrinsic factor, therefore you don't have a carrier for the B12 into the bloodstream. So this is a patient with high hemoglobin of 18 gram per deciliter with an on and off burning sensation and erythematous changes. This is called erythromelalgia, which is found in patients with polycythemia vera, which is a peripheral vascular disease causing some painful episodes in which there is an episodic blockage of the blood vessels followed by hyperemia. So the melalgia, do you see it? Okay, here. So the red hand is the pathologic hand. So polycythemia vera is an increase of hemoglobin due to a JAK2 mutation in the hematopoietic stem cell, and with a male predominance at the median age of 60 to 65. Usually they present with headache, fatigue, pruritus. They all usually have high blood pressure, splenomegaly, and pulmonary hypertension. They tend to get gouty arthritis in between. It's very important to rule out secondary causes of erythrocytosis, since the polycythemia vera only accounts for only 5% of all patients with absolute erythrocytosis. And some patients, they might have a relative erythrocytosis due to fluid or plasma loss. So shifting gear to the WBC count abnormality, a 74-year-old male referred from cardiology clinic with a high WBC count. He is asymptomatic. He has no lymph nodes and no splenomegaly. His WBC count was 78,000, hemoglobin 13.2, and platelet of 256, and mainly a lymphocytic predominance. So as you can see, this smear showing a small rounded mature lymphocyte and smudge cells. And this is a patient with chronic lymphocytic leukemia, which is discovered incidentally in almost 80% of the patients. So the approach to lymphocytosis, the first thing you do is to ask a full history and take a full examination, do a full examination to rule out any secondary causes. And then we do something called flow cytometry, and to see whether the lymphocytes that are present are clonal or polyclonal, meaning they belong into one type of lymphocyte or different type of lymphocyte. So if they are clonal, then we leave it to the hematologist to decide whether this is a CLL or other lymphoproliferative disorder. And if they are polyclonal, we go back and look for the secondary cause. Case number 2, a 52-year-old male with the symptoms of heart failure. 4 weeks ago, he had a chronic abdominal pain, and recently he had non-healing oral ulcers. Examination, he looks ill, and the vitals were normal. He has a diffuse erythroderma and high JVP with basal crepitation. His hemoglobin was normal, WBC 18,000, male with eosinophil of 10%, which is high. Peripheral smear showed mature eosinophilia, and echo showed a restrictive LV filling defect with mitral regurgitation. And the secondary causes of eosinophilia were excluded. So this is a patient with hypereosinophilic syndrome. So there is new proposed classification for hypereosinophilia. If there is any mutations in the hematopoietic stem cells, then like BDGFRA or P, and Feb1L1, then this is a patient who has truly a clonal disease due to a stem cell disorder. And sometimes you have something called a lymphocytic variant of HES, which is related to some lymphoproliferative disorder. Here we do a flow cytometry for the T cells, and then we can pick them up. Overlap HES, which is restricted to one organ, like pneumonia, like eosinophilic pneumonia or eosinophilic esophagitis. Associated HES, which is related to another autoimmune disease like sarcoid, IBD, drugs or infections. Idiopathic, which is a multi-system, you don't have any other features of secondary causes like our patients. Then, and this is just an approach to eosinophilia and what are the possible etiologies. So the initial evaluation includes CBC biochemistry quantitation of the IgE level, including IgE, troponin for the cardiac involvement, B12 and tryptase, usually elevated in patients with a truly hematological problem, parasitic serology in patients who had a previous exposure to parasitic infection, echo sometimes is done, CT and PET scan looking for lymphomas or other malignancies, BFT if they have respiratory symptoms, and tissue diagnosis is essential by bone marrow biopsy, cytogenetics, and flow cytometry, or we go to the organ that is affected, like lungs, esophagus, or skin. The treatment options depending on the clinical status of the patient. So if he has a cardiac, neurological, or thromboembolic, or very high eosinophil count, then you have to start steroid as soon as possible, ranging from 1 milligram per kg up to 1 gram a day. Ivermectin should be given to all patients who are having a potential exposure. Patients who did not respond to steroid can be given hydroxyurea, imatinib, or interferon. Case number 3, a 29-year-old man from Ethiopia presented for evaluation for neutropenia. He has no previous medical history. His primary care physician found that his ANC is 1100, otherwise unremarkable peripheral smear. So the probable diagnosis, this is a patient we commonly seen with isolated neutropenia, and the etiology ranging from a self-limited disease into a life-threatening condition. So the causes of neutropenia include either congenital or acquired, constitutional, cyclic, benign familial, or severe congenital neutropenia. The cyclic neutropenia is an autosomal dominant congenital type that occurs in episodes every 2 to 5 weeks with oral ulcers and some febrile illnesses, and requires an urgent or regular CBC follow-up. Constitutional or ethnic, there are some ethnic background that they tend to have a lower neutrophil count with regard to, in comparison to the general population, like Mediterranean, especially Yemenis. And severe congenital neutropenia is a life-threatening condition, commonly observed in children. However, there are some late onset of severe congenital neutropenia, which carries a risk.
We have 2 minutes left.
Okay. So it carries a risk of acute myeloid leukemia. So, but with the advent of GCSF, the mortality has improved dramatically. Some go to the algorithm for evaluation and treatment of patients with neutropenia. So if the patient is acutely ill, so at the triage, the physician should consider a fundamental question whether there is a severe neutropenia and fever, then admission, IV antibiotics, and further evaluation. If it's a new onset, if it's not a new onset, then we think about familial type. If there is any drug or infection, other cytopenia present, we will check for B12 and folate. And if there is none of them, then we go for a bone marrow evaluation. So this is a 24-year-old Kuwaiti male on a pre-employment screening found to have a platelet of 20,000. So the first thing you do is to check he's previously healthy and has no symptoms, and clinically he's fine, is to repeat the CBC with peripheral smear evaluation. So the possibility of pseudo-thrombocytopenia should be eliminated before any intervention is undertaken, ruling out 2 things, the platelet clumping and platelet satellitism, and sending another CBC using a non-edit tube. The same patient with a platelet of 20, but he has symptoms of epistaxis and petechial rash. A smear showed a large giant platelet, and diagnosis of ITP was made. So which of the following treatment options will result in a quick response of the platelet count? So IVIG is the answer. So ITP, it could be a primary or secondary, and it's a diagnosis of exclusion with a female predominance, and the symptoms start when the platelet count less than 30 with mucocutaneous bleeding. And as you can see, IVIG is usually raises the platelet count within 24 to 48 hours. However, the effect is transient and is mostly used in patients who has a severe life-threatening bleeding or pre-procedural. And the treatment is usually steroid at the first line, and then if the patient failed, we have to go for a second line, which include splenectomy, rituximab, or thrombopoietin analog. So with regard to splenectomy, open and laparoscopic splenectomy offered almost similar efficacy and safety profile. So depending on the center experience, you can proceed with either one. The patient should be vaccinated either prior if you're planned for elective splenectomy, or after splenectomy 2 to 3 weeks after. With regard to antibiotics in a splenectomized patient, I think the benefit of lifelong antibiotic is questionable. However, a practical approach is to suggest to the patient to take antibiotic once he has a fever and come to the emergency room. Do you have more time?
Half a minute.
Okay.
This ferocity
So
of
this is, okay, the scenario here is dealing with a patient with heparin-induced thrombocytopenia. So the first thing you do is a 40 score, which is a clinical scoring system to predict the possibility of HIT. So based on 40s, like the degree of thrombocytopenia, timing, thrombosis, and the other diagnosis of thrombocytopenia. And the patient will be divided into 3 risk categories: low, intermediate, or high. And this table used in conjunction with the 40 as well as the platelet factor 4 antibodies by ELISA. So if you have a low probability, pretest probability, and negative BF4, then HET is ruled out. But the thing that I would like you to highlight here is if you have a high pretest probability and a negative HET, this does not exclude it 100%. You still have a 16% chance of possible HET, so it's better to proceed with SSRI, which is SRA, which is serotonin release assay. Patients should stop all forms of heparin, and they can be given a non-heparin agents. Warfarin, fondaparinux, and a new oral anticoagulant can be given based on systemic reviews and meta-analysis in patients with HET. The duration of anticoagulant here is depending on the presence or absence of thrombosis. So if there is no thrombosis, then you give for 4 weeks, and if there is a thrombotic event, then you give it for 12 weeks. And the patient should not get any heparin in his lifetime. I think I will stop here. This is a patient with TTP. And thank you so much, and happy to get any question.
Thanks, Dr. Ahmad. Dr. Jihan will present our